Why does the shoulder dislocate most commonly anteriorly and not superiorly or posteriorly? The answer is not anatomy, it's kinetics. Till now, in part 1 and 2, we have understood shoulder anatomy and kinematics, basically what moves and how it moves. But today, it's where things become clinically powerful because in this lecture, we are not just studying movement, we are understanding the forces behind the movement. And once you understand shoulder kinetics, muscle imbalance becomes obvious, injuries make sense, and exam questions become predictable. So, in this session, we'll break down joint wise kinetics, muscle force couples, and most important, clinical applications. A brief review of the four joints which we have studied in the previous parts. So first comes the sternoclavicular joint. The sternoclavicular joint is the only structural attachment linking the entire upper extremity, that is entire appendicular skeleton, to the axial skeleton. Next comes the acromioclavicular joint. This allows the scapula to rotate in 3 degrees to stay congruent with the thorax. The next comes the most mobile, your glenohumeral joint, which has maximum mobility, which compromises the stability. And next comes the scapulothoracic joint, which is not a structural joint, it is a functional joint, and it relies entirely on the acromioclavicular and sternoclavicular joint for its integrity and is supported entirely by muscles. Always remember, the shoulder relies primarily on the active muscle forces, that is kinetics, and not on bony congruency for stabilization. This is very important for your MCQs and Viva. Now, during this quick revision, how can we miss the most important topic, that is scapulohumeral rhythm? So, as we know that 120 degrees of glenohumeral movement combined with 60 degrees of scapulothoracic movement gives a total of 180 degrees of elevation. That is, the ratio of 2 is to 1 of glenohumeral to scapulothoracic movement gives the scapulohumeral rhythm. Now this entire combined motion distributes movement across the joints to prevent extreme compromise of stability and to maintain the correct kinematics, and also to prevent any abnormal or dysfunctional movement. This also maintains the glenoid fossa in an optimal congruent position beneath the humeral head and prevents active insufficiency or any dislocation, impingement, or abnormal kinetics or movement dysfunction. Always remember, to achieve 60 degrees of scapulothoracic upward rotation, the clavicle must elevate, retract, and posteriorly rotate at sternoclavicular joint. This is very important for your Viva and your exams MCQs. As we are aware of the articular mismatch due to the small size of glenoid fossa as compared to the large, huge size of the head of the humerus. This articular incongruency is maintained by scapulothoracic base. This means that the scapula moves on the thorax in such a manner so that the glenoid fossa always is in congruence with the head of the humerus during upper limb movement. That is why this is called as the ultimate dynamic stabilizer. Also remember, this articular incongruence always requires massive muscle, that is kinetic support. Kinematic forces and kinematic movements always are there, but the major support is by kinetic muscle support. And there are always shear and compressive forces. These forces causes joint reaction force to reach to a significant increase in number during the weight lifting or any movement of the upper limb during elevation. For your exams, always remember that peak shear forces in the glenohumeral joint occur during early times, specifically between 30 degrees to 60 degrees of elevation. Discussing about the load transmission, that is, it happens between the proximal links, that is the sternoclavicular joint, and the acromioclavicular joint. The entire load of our appendages, that is appendicular skeleton, goes to the axial skeleton via these two joints. Please remember this for your exams. Let's discuss the sternoclavicular joint first. We know the articular surface is a saddle shaped surface with a fibrocartilaginous disc in the joint cavity. So this articular surface rarely causes degeneration because it is not in congruence with each other. This helps to dissipate the massive forces which are transmitted from the upper limb to the axial skeleton, and also this is assisted by the costoclavicular ligament. Due to the dissipation of the forces, no particular point on the articular surface gets compressive forces, and that is why it escapes degeneration. So where do you think the degeneration happens then? Of course, there is acromioclavicular joint which is there to take up these forces. Now here we know the articular surface has a plain synovial joint cavity with small facets and high force per unit area. Because the joint cavity is small, the entire pressure is going to be more. Therefore, it is prone to trauma and degeneration. Very important for your CET and your clinical practice. Acromioclavicular joint is one of the most commonly joints which undergo degenerations. Now, this force transfer happens via the coracoclavicular ligaments, which transfer the upper extremity weight to the clavicle. We will be discussing this in the next slide. So ligament importance is the coracoclavicular ligament is the primary kinetic suspension bridge of the entire upper extremity. Please snapshot this or just remember this for your CET. Note it down because this is very important and a frequently asked MCQ. Which ligament is the primary kinetic suspension of the entire upper limb? The answer is your coracoclavicular ligament. The load transmission of the upper limb to the axial skeleton occurs via this mechanism. So the medial forces on the head of the humerus transfer to the clavicle, the entire clavicle, and to the axial skeleton via the coracoclavicular ligaments, ultimately dissipating the force safely into the strong sternoclavicular joint. So this happens via the coracoclavicular ligament, which is very important. So the transmission happens from the head of the humerus to the acromioclavicular joint and the coracoclavicular ligament, which has two portions, the conoid portion and the trapezoid portion, as we have discussed in the previous lectures. So conoid portion is the primary restraint against superior directed forces because it is oriented vertically, and trapezoid portion is the primary restraint against medial displacement and posterior directed forces due to the direction of its fibers into a horizontal or oblique direction. Now, the head of the humerus passes the force to acromioclavicular joint, which via the coracoclavicular ligaments pass the force via the clavicle to the sternoclavicular joint and the costoclavicular ligaments and ultimately into the appendicular skeleton. Now, these highly incongruent surfaces of the clinohumeral joint are protected by the static and dynamic stabilizers. Let's discuss the static stabilizers. So, we always have to remember that muscles are electrically silent as examined on EMG and they are relaxed during dependent arm conditions. That is, stabilization is 100% passive. However, the findings suggest that supraspinatus muscle is the only muscle which is active when the arm is heavily loaded and kept in a resting dependent position. How does this work? So there are four pillars of static stability. The first comes the rotator interval capsule, which includes superior glenohumeral ligament, the superior capsule, and the coracohumeral ligament. Next comes the upward structural inclination of the glenoid fossa, which we see there is a bony notch coming out from the glenoid fossa, which acts as a bony block and prevents the inferior translation of the head of the humerus. There is always negative intraarticular pressure, that is, a vacuum like pressure is created by the glenoid labrum, which holds the head of the humerus. This negative pressure prevents the dislodging of the head of the humerus and inferior translation. So the mechanism is like gravity pulls inferiorly and the passive tension of the rotator interval capsule, which gives a superior pull, and compression, which comes as a result of the force stabilizing the joint. So gravity pulls down, rotator interval capsule pulls up, and the vacuum sucks in. Dynamic capsular restraints. So these are actually the ligaments. They are not dynamic restraints. They come under static restraints. But each of the component of inferior glenohumeral ligament complex works at a different range of motion. That is why we have classified it under dynamic movement. So ligament restraint is highly position dependent. So at 0 degrees, that is when your arm is resting at the side, the superior glenohumeral ligament limits the inferior translation because it is holding the head of the humerus, is held with the coracoid process and the scapula by a superior glenohumeral ligament complex. Next comes when the arm is moving from 0 to 45 degrees of abduction, the middle glenohumeral ligament limits the anterior translation. Here the head is prevented from coming anteriorly out. Now, at more than 90 degrees of movement, the inferior glenohumeral ligament complex, which acts as a primary hammock, as we have already discussed, so it actually twists on itself to prevent external rotation as the anterior band fans out, and internal rotation is prevented as the posterior band fans out. So we know that inferior glenohumeral ligament complex tightens up into entire abduction and external rotation, which is the close pack position of the glenohumeral joint. Along with the static stabilizers, there are two most important assistants to static stabilizers, which work when they fail entirely and they assist them in the normal movements. So first comes the supraspinatus and then is the biceps. Let's discuss supraspinatus. So the force vector of supraspinatus is in this direction. When you resolve this vector, it gives us two superiorly translatory component, that is one, and the other is the rotatory or compressive force vector. Now, because it is a compressive force vector acting in this direction, means it pushes, that is compresses the head of the humerus into glenoid fossa. It is an independent abductor and most critical dynamic joint compressor. Next comes the long head of biceps. Now the long head of biceps, as you see in the diagram, goes like a roof over the head of the humerus and then centers into the bicipital groove. This helps centering the head into the fossa, and it reduces the vertical translation because it's like a roof, and anterior translation because it comes anteriorly into the bicipital groove. Very important CET MCQ and more than that in your clinical practice. The biceps tendon commonly hypertrophies in patients with rotator cuff tears to compensate for stability. Now we know that rotator cuff provides stability, but what when it is lost? If you have tears or any pathology involving the rotator cuff, your joint is not dislocating. Why? Because there are other participants, other stabilizers which come into action. One of them is the biceps tendon. Now continued movement of protection and continued work on the biceps tendon causes hypertrophy into that tendon. Most favorite are 7 marker, also your MCQs, and this maybe forms the whole basis of your rehabilitation, I would say. So this is the ultimate force couple of the deltoid versus rotator cuff. Deltoid is the problem, then what is the solution? Let's understand. So just don't judge my diagram, please, and let's try understanding with this rough diagram which I have drawn to explain. Consider this yellow line as the deltoid muscle. Now the pull of the deltoid is in this direction due to its fiber alignment. Now when you resolve this vector, you get a rotatory component and one translatory component. This translatory component, the superiorly directed translatory component of humerus, the deltoid, is so huge that it cannot be compensated even by gravity at rest. Now, if gravity is not compensating, this humerus head is going to just dash the acromion and cause impingement of all the structures in the subacromial space. Now, what to do for this translatory component? And there is one important thing, that until translatory component is compromised, the rotatory component cannot act. Means deltoid cannot act as an abductor until this translatory component is compromised. So let's jump to the solution, that is ITS. What is ITS? The three muscles, that is the infraspinatus I, teres minor and not major, and S stands for subscapularis. All these three work together as a rotator cuff, which provides an inferior translatory pull. This perfectly offsets the deltoid superior pull and converts the energy into pure rotation, because if the translatory pull superiorly is compromised, now deltoid's rotatory component can act and rotation of the shoulder joint, glenohumeral joint, can happen. Please remember this: without ITS, the inferior pull, deltoid cannot independently abduct arm. In one of the previous slides, I told you that supraspinatus acts as an independent abductor. Let's understand how this happens. So this is the force vector of supraspinatus muscle. This is due to its force fiber muscle directions. When you resolve this, you get a superiorly translatory FX component and an rotatory or compressive FY component. This superiorly translatory FX component of supraspinatus is not like deltoid. That is, it is little weaker, so it can be compromised and offset by the gravity pull. So this FX component is not going to cause impingement. Now we are left with Fy component, which is a compressive, that is stabilizing effect, and also rotatory. Therefore, supraspinatus can independently rotate without help of any other muscles, as opposed in the case of deltoid, which needs rotator cuff muscles, that is ITS muscles, to prevent its superiorly translatory pull. That is why supraspinatus is called as an independent abductor. The advantage is that it of course cannot offset the deltoid's upward pull, but it has a large momentum because the insertion rides, so supraspinatus muscle rides over the head of the humerus. Now this causes a large distance to span from the joint axis till its insertion. We know from the Lever's lecture that larger the momentum, less effort is required to complete the required range of motion. So it has a large momentum and superior location, which allows it independently produce glenohumeral abduction with while compressing the joint. So we have two functions. One is stability and other is compression provided by the supraspinatus muscle. The gravity acts as a passive synergist because it helps the offsetting of the superiorly translatory pull of the supraspinatus. Please remember this for your exams and rehabilitation in a fully paralyzed deltoid. So we consider this case scenario in which a patient comes with a paralyzed deltoid. If your supraspinatus muscle is healthy, the patient will yet be able to initiate and complete arm abduction because it is an independent abductor. One more case scenario which I would like to discuss is in a stroke patient when all the muscles are paralyzed. The entire joint relies only on the passive structures, that is the ligaments and the capsules. Over a period of time, if the rehabilitation does not happen, then these passive structures also lose and enter into a elastic range. So this causes a deltoid sulcus sign which we see in stroke patients, and that causes shoulder impingement and further complications which we will discuss later. Moving on to scapulothoracic upward rotation. So this is provided by three main muscles. Though all the muscles participate, these are the three main muscles which provide vector directions for scapulothoracic upward rotation. First comes the serratus anterior. So serratus anterior pulls out and up. So serratus anterior causes the scapula to move out and up. That is the lateral translation. If this lateral translation would not happen, there will be winging. That is the internal border. Medial border of the scapula will pop out along with the inferior angle. This maintains a massive momentum throughout the entire range of elevation. Next comes the upper trapezius, as we see in this direction. This pulls the clavicle up and in, that is retraction and elevation of the clavicle. Okay. Next comes the lower trapezius, which acts in unison with the upper trapezius and pulls down and medial translation. So if this is your scapula, the upward movement is happening by the trapezius muscle, upper trapezius. This is compensated and kept into range by the lower trapezius, which pulls down and in, that is medial translation. And this scapula doesn't ride off the thoracic cavity due to the serratus anterior, which keeps it attached to the thoracic cavity by providing outward and upward, that is lateral translatory movement. Remember this for your exams. As elevation progresses, The axis of upward rotation shifts laterally towards the acromioclavicular joint. So actually this scapular upward rotation begins at the sternoclavicular joint initially. This axis gradually moves from medial to lateral direction and ends at the acromioclavicular joint and then the glenohumeral joint during entire abduction or elevation moment. I have made a rapid revision matrix for you which you can just snapshot right now so that this helps you in a quick revision for your CET MCQs. So I've made two tables, one is static stabilizers and other comes the dynamic stabilizers. Static stabilizers includes negative intra-articular pressure, the vacuum, clinoid upward inclination that is the bony block, the labral seal and the rotator interval capsule at 0 degrees of abduction. Dynamic active stabilizers include rotator cuff that is ITS muscles which provide the inferior glide and also help offset the superior translatory force of deltoid. The supraspinatus muscle which has a compressive force vector, the long head of biceps which is into the center which helps center the head of the humerus into fossa and scapular upward rotators that is serratus anterior and trapezius which prevent offsetting or overriding of scapula outside the entire shoulder biomechanics. So always remember that static stabilizers rely on tension and vacuum. Dynamic stabilizers rely on force, couples and compression provided by the muscles. Quickly snapshot this matrix 2 of revision again for your CET quick revision. Every structure has certain function which I have listed down here. So first comes the static suspension at rest which is provided by the rotator interval capsule, the superior glenohumeral ligament, the coracohumeral ligament and the negative vacuum pressure created by the labrum and the capsule. Next comes the glenohumeral dynamic rotation, which is mainly provided by the force couple of the problem deltoid and solution ITS, we know, which provides a downward translatory component which helps offset the high superior translatory component of humerus, preventing impingement. Next comes the independent glenohumeral abduction. I am sure when you see the word independent abduction, you can directly now say supraspinatus and its superiorly translatory component can be offset by gravity. Next comes the scapular upward rotation, which is provided by two muscles which participate in a force couple, that is serratus anterior and trapezius. Trapezius, both the upper and the lower trapezius participate in this. Scapular downward rotation is provided by the pectoralis minor muscles, rhomboids and the levator scapulae. Maximum glenohumeral shear force occurs at 30 to 60 degrees of clavicle elevation. Just snap this screenshot for your 5 minute CET revision. Now that we are thorough about the normal biomechanics, kinetics and kinematics of shoulder complex, we can discuss about the pathomechanics. Let's come to impingement and rotator cuff failure. Now we discussed that deltoid has a superiorly translatory force which cannot be offset by anyone but only the rotator cuff muscles. What if these muscles themselves undergo weakness, fatigue, or there is tearing of these muscles? Now, the deltoid superior translatory component is not going to be offset by any inferiorly directed components. That is, deltoid's massive component is going to be unopposed. What will happen as a result? The humerus head is going to go translate up and just impinge all the structures in the subacromial space. This is like a vicious cycle. So pain, fatigue or weakness of the rotator cuff muscles causes the rotator cuff inhibition because the body naturally tends to undergo guarding. Now if rotator cuff muscles are not acting, who's going to act? The deltoid definitely. This deltoid will cause impingement by translating superiorly and this impingement will again cause pain and this is an entire cycle until we intervene and break it. So patient comes with a painful arc of pain between 60 to 120 degrees of arm elevation and the patient says that the pain goes away after 120 degrees. Why does this happen? Because the tendon actually rotates safely past the acromion. The supraspinatus tendon. So the pain vanishes. Always remember this as an important indicator towards the subacromial impingement. Remember this for your rehabilitation, that impingement is not structural initially, it is always kinetics. We saw, right? There is muscle imbalance because of which the impingement is happening. So impingement is always kinetics problem, muscular problem before it becomes a structural problem. If this kinetics, muscle imbalance is not corrected, not motor control is not obtained properly, then gradually it will end up into a structural problem. Moving on to mechanics 2, that is altered scapular force couples. Now we know that scapular force couples is provided by two major muscles, that is the trapezius and the serratus anterior. Now the pathology includes long thoracic nerve palsy, which supplies the serratus anterior muscle, which will undergo paralysis if that nerve is affected. Loss of serratus anterior massive lateral and upward movement arm will cause into a biomechanical dysfunction. The unopposed downward pull of the gravity is going to pull downwards along with the trapezius and deltoid forces. Now these all will result into a downward rotation, internal rotation and anterior tilting. Means the medial border and the inferior angle of the scapula is going to tip outwards. That is scapular winging. Now this scapular winging happens not only because of the serratus anterior muscle weakness, but because of the unopposed muscle action of deltoid, trapezius, and of course the gravity. Remember this for your clinical rehabilitation. A patient will complete serratus anterior paralysis cannot elevate their arm post 60 to 75 degrees. Why? Because the deltoid now simply downwardly rotates. So deltoid's function is to rotate the scapula upwards. But now since the serratus anterior stability is not present, instead of moving the whole huge humerus, which is heavy, into abduction, the muscles will try to move the scapula, which is light in weight, into the downward rotated movement, and this will cause the downwardly rotation of the scapula instead of lifting the heavier arm. So abduction will happen only 60 to 75 degrees by reverse muscle action of deltoid. Pathomechanics 3, that is glenohumeral instability and the vacuum seal mechanism. We know that the glenoid capsule and the labrum holds the head of the humerus into the glenoid fossa via negative intra-articular pressure created. Now, if this capsule disrupts due to dislocation or any tears in the capsule or into the labrum, there will be loss of the negative pressure. Now, this pressure was giving stabilization, was acting as a static stabilizer and preventing inferior translation of head of humerus. Loss of the stabilization will cause inferior translation of the humerus down from the glenoid fossa cavity. What will be the biomechanical consequence of capsular dysfunction? So venting the capsule instantly destroys the negative intra-articular pressure, that is the vacuum seal, and this results in massive increases in inferior translation even at rest. The inferior glenohumeral ligament complex tears. Now this was preventing abduction and lateral and medial rotation. This results in profound anterior instability, specifically when arm is in position at 90 degrees. This is the most common position of dislocation of shoulder joint. Abduction combined with external rotation. Let's take this rapid fire for your quick revision. Just respond to yourself and check if you know and if you can answer this correctly. The primary restraint to inferior translation at 0 degrees is thoracohumeral ligament and superior glenohumeral ligament rotator interval. Also, you have to answer what is the primary restraint at 45 degrees and 90 degrees of abduction in the comments. Next comes prime mover for scapular upward rotation. It is the serratus anterior due to the largest moment arm. Always remember for CET MCQs, the muscle with largest moment arm is serratus anterior in the shoulder complex. What happens if the ITS muscles fail during abduction? The deltoid will not fail. It is going to overact and cause impingement. At 90 degrees of abduction, what stabilizes against anterior translation? Just now you have recollected, it is the inferior glenohumeral ligament complex. High yield points and key takeaways for Viva and CET. Take a snapshot of this slide. This will help you for your quick revision. The only bony link is the sternoclavicular joint, which is a structural attachment of the appendicular to the axial skeleton. Zero muscle energy, that is resting arm stability, is 100% passive, provided by the vacuum and rotator interval capsule, not active muscle contraction, according to EMG. The deltoid's best friend is the rotator cuff. It is essential not only for strength but also to prevent superior dislocation by offsetting the deltoid superior translatory force. The shifting axis, the axis of the shoulder upward rotation dynamically shifts from medial, that is spine root and the sternoclavicular joint, to lateral to the acromioclavicular joint during arm elevation. Let's quickly revise the most important key takeaways from today. Shoulder movement is not just motion, it is a controlled kinetic force. Force couples are the key to stability for shoulder complex. Muscle imbalance directly leads to dysfunction and injury. If you understand kinetics, you understand the shoulder. If you are preparing for your exams like CET or basic UG foundation, even want to strong clinical concepts, this is exactly what we focus on in my mentorship program. Not just theory, but how to think clinically, how to solve MCQs faster, and how to actually retain concepts long term. Details are in the description. You can check it out after the video. Thank you for being with me throughout this lecture. If it made your concepts clearer, don't forget to like, share, and subscribe. And I'll see you in the next part.